starting with scientific session 5, which is sponsored by Dr. Anil Kumar Srivastava sir in the loving memory of his wife, late Srimati Meena Srivastava. So we'll be starting with scientific session 5, which is molding values and interest in occupational therapy practices.
Are all the participants of scientific session 5 here?
Dr. Sanjeev Kumar, Dr. Kanishka Mehta, Dr. Madhu Mitra, Dr. Kaushalya, Dr. Simran Sandeep, Dr. Meenakshi Batra. Now I request Dr. Zareen Farzani ma'am to come on the stage and chair the session, scientific session 5. Dr. Zareen Farzani is head of Occupational Therapy Department at Masina Hospital, Mumbai, former associate professor at OT Training Center and GS Medical College and KEM Hospital, Mumbai, pioneer in starting OT in Drug Addiction Center of Excellence at KEM Hospital. She was editor iJot for 12 years, AIOTA office bearer for 34 years, fellow of ACOT Accord in 1993. She won AIOTA Professional Excellence Award in 1999 and President's AIOTA Crown of OT Award in 2013, and her area of interest is mental health and neurological disorders.
Good afternoon, everyone. Can I have the list, please? Shivani? We have 6 presenters. All 5 are
So next chairperson for scientific session 5 is Dr. Bhumia Desari, and he will be, again this is the same slide. This is wrong. No. Yeah.
Well, I'm glad Dr. Dasari has agreed to be the co-chairperson. Well, we have 6 presenters in this session, scientific session 5, out of which 5 are competitive and 1 is a non-competitive presentation. Are you all ready? Well, I call upon the first presenter. The topic is effect of pressure along with vibration through face roller on drooling and swallowing in children with cerebral palsy. The presenter is Dr. Sanjeev Kumar from Chandigarh. Your time begins now.
Good evening all. Today I am going to present about effect of pressure along with vibration through face roller on drooling and swallowing in children with cerebral palsy. Introduction. Cerebral palsy has been described as a group of disorder of the development of movement and posture that are attributed to non-progressive disturbance that occur in the developing fetal and infant brain. Drooling is a stigmatization for significant portion of cerebral palsy in children. The prevalence of drooling 44 and swallowing 50 and feeding problem 53% respectively in CP children. Oral motor strategy are used to increase functional feeding. The use of vibratory stimulus has demonstrated the practical application in the area of therapeutic rehabilitation and exercise performance. The repeated muscle vibration is a proprioceptive impulse that activates the fiber A and reaching the somatosensory and motor cortex. The need for this study, the children with cerebral palsy, they have drooling, swallowing and feeding problem which are very common. Oral motor strategy suggested the use of vibration, quick stretch to decrease drooling and facilitate jaw and lip closure. Author would like to suggest that neurophysiological intervention is complicated treatment modality with many questions of short-term and long-term effect on myriad condition, still needing to be answered with extensive practical research rather than with theory and subjective opinion. But there is no research evidence on implementation of jade roller or face roller therapeutically to control drooling and hence swallowing. Hence, this study focused on use of face roller, improve drooling and oral motor performance. The aim of the study to find out the effect of pressure along with vibration through face roller on drooling and swallowing in children with CP. Objective to evaluate the drooling control of children with CP and to demonstrate the effect of face roller in controlling drooling and hence swallowing in children with CP. Alternative hypothesis or pressure along with vibration through face roller is effective in controlling drooling and hence swallowing in children with CP. Null hypothesis or pressure along with vibration through face roller is not effective in controlling drooling and hence swallowing in children with CP. Methodology. I used pre-test and post-test single group design and quantitative study and convenient sampling technique. Total sample size was 30 and the dependent variables or frequency of drooling and swallowing. Independent variables or pressure and vibration through face roller. Next, the selection criteria. Children aged between 2 to 7 years and both gender male and female children who diagnosed with CP and presence of drooling, and children those will follow the basic instruction and swallowing and feeding problem as for the mother, and drooling score more or equal to 3, drooling severity and frequency scale, those were included in this study, and the moderate and severe mental retardation and presence of cleft palate and cleft lip, and any previous surgical procedure for drooling control, the use of drugs that interfere with saliva secretions, those were excluded from this study. The screening tool used drooling severity and frequency scale, DSFS, and outcome measure, DSFS, and oral motor assessment scale, UMAS. The procedure, after obtaining the ethical committee permission, subject was selected from the Paediatrics section of Department of Occupational Therapy. The pre-test data were obtained by the use of DSFS and UMAS. The intervention for 2 months and 5 days in a week and 20 to 30 minutes a session. At the end of the intervention, the post-test data were obtained. The treatment protocol, the position of the child will be seated on the CP chair with cutout lap board to keep the trunk upright, and shoulder and arm should be rested forward on the lap board. The hip and knee are flexed 90 degree and ankle 90 degree and feet firmly rested on the footrest. So here I use the 3 steps: warm up 5 to 10 minutes and specific protocol 10 to 15 minutes, and wind out is 5 to 10 minutes. So next is, during warm-up phase, the vibration has been provided in the form of set, which consists of 5 repetition and 2 set of vibration was given. Step 1, the vibration was given initially via from rub by use of face roller having the circular head on the each side of the mouth. The vibration is given from the ear and to the corner of the mouth, both side of the face. And step 2, the vibration was applied on the lower jaw from the center of the chin towards the upper lip and dragging the face roller laterally in the both side. Step 3, the vibration was applied on the both side of the upper lip and lower lip. Step 4, the vibration was given from the center of the upper lip and towards the center of the lower lip by dragging the face roller, and the pressure was given at the center of the lower lip, and similar procedure was done at the other side too. The specific protocol, the pressure vibration was given by the use of face roller, the both side of the face followed by specific protocol. The step 1 vibration and pressure were applied over the orbicularis oris muscle, and step 2 were applied from the ear to the center of the mouth, and step 3 vibration and pressure given under the chin and followed through the ear, and step 4 it was applied both side of the larynx from the chin to sternal notch. The wind out, the simulated feeding performance by swallow the mashed food items like rice ball and lemon juice and mashed potato and water. These are the few pictures. Next, data analysis and results. So I used SPSS version 20. So this is the demographical data. This table describes the details of pre-test and post-test score of DSFS and UMAS. So this table is described the comparison of pre-test and post-test score of DSFS and UMAS. So here the UMAS score is 8, where post-test score was 15. It suggests there is an improvement in swallowing in after the intervention. The DSFS score 6, where the post-DSFS score 3. It suggests there is a frequency of drooling is decreased after the intervention. So this graphical representation, it shows the pre-test and post-test score of DSFS and UMAS. The discussion. The aim of the study was to find out the effect of pressure along with vibration through face roller on drooling and swallowing in children with CP. The result of the current study shows there is a significant improvement in the swallowing in CP children who had taken the intervention of pressure along with vibration through face roller. This finding is strongly corroborated by author who claimed that applying pressure on the oral facial region can enhance the oral facial tone and improve swallowing by the oral facial awareness and facilitation of jaw and lip closure. The above results also supported by the research in which it states that neurophysiological treatment program based on the use of proprioceptive stimuli such as light touch and vibration and icing can assist the development of normal movement pattern. As this current study, the neurophysiological treatment bases on the principles of proprioceptive stimulation such as pressure along with vibration was provided to the subject of CP through face roller. It could have been the reason for the improvement of swallowing in CP children. The second significant result has been observed in the current study is that the frequency and severity of drooling was reduced after the intervention. This result supported by the vibration therapy enhanced to reduce the hypertonicity and facilitate the lip closure and jaw control, which subsequently reduce the frequency of drooling. This justification also hold true for the current study as the children in the experimental had received the pressure along with vibration around the face, which has been the lead to the reduction in the frequency and severity of drooling. The additional feedback was also received from the parent that the child is able to drink water from the tumbler with minimal spillage and chew the vegetables, which were the difficult task before the intervention. So here the conclusion, after the 2 months of the intervention program, pressure along with vibration through face roller has controlled the frequency and severity of drooling, the improved swallowing, hence the acquisition of oral motor control. Therefore, the significant improvement can be considered as the efficacy of intervention program. It suggests, therefore, the null hypothesis rejected and alternative hypothesis accepted. The findings of the current study encourage the use of pressure along with vibration by the face roller as mean of occupational therapy intervention to control the drooling and improve swallowing. So these are the limitations like small sample size and single study design is single group. The generalization is limited in the single geographical area and recommendations can be conducted in the randomized control trial. And further study the schedule of oral motor assessment SOMA and functional feeding assessment FFAM. The findings further encourage the oral motor performance, the use of functional feeding as a mean of occupational therapy intervention. And these are my references. Thank you.
Can I call upon the second speaker, Dr. Kanisha Mehta? She's going to speak on effectiveness of interlimb coordinated activities on the development of postural control in children with spastic diplegic cerebral palsy.
A very good evening to one and all. This is Kanishka Mehta. I am presenting my research title, Effectiveness of Interlimb Coordinated Activities on Development of Postural Control in Children with Spastic Diplegic Cerebral Palsy. Cerebral palsy is a persistent disorder of movement and posture resulting from non-progressive brain abnormalities. Most of the cases are spastic type, predominantly spastic diplegia, primarily affecting bilateral lower extremities. Its defining characteristics are loss of selective motor control, imbalance of muscle across the joints, aberrant muscle tone, and impaired equilibrium reactions. Children with spastic diplegia struggle with adapting sensory and motor components of postural control, affecting their response to balance disturbances and recovery from threats to stability. Biomechanical limitation further have an impact on functional skills. Balance is an essential aspect of postural control. Interlimb coordination refers to the movements that require rhythmic, sequential, and simultaneous use of both the sides. It can be classified as bimanual coordination and hand and foot coordination. It is known as neural coupling to describe the connection. Therefore, combining movements of the bilateral upper and lower limbs promote motor learning and recovery by facilitating interlimb coordination and enhancing activity-dependent plasticity. The association between interlimb coordination and postural stability has been observed in both pathologic and non-pathologic children. Therefore, it is conceivable that interlimb coordination is linked to the developing process of dynamic balance regulation. Sidropoulos et al. In 2021 demonstrated that intensive upper extremity training improved whole body movement control in unilateral spastic cerebral palsy. Huang et al. In 2009 concluded valuable insights by revealing the influence of interlimb neural coupling on muscle recruitment during maximal effort upper and lower limb rhythmic exercises. Furthermore, Blindheads in 2017 concluded that habitile approach holds promise for enhancing whole body movement control in children with bilateral cerebral palsy. This emphasizes the importance of addressing interlimb coordination comprehensively as opposed to focusing solely on unilateral cases. These findings underscore the interconnected nature of neural connections and highlight the potential for intervention promoting coordinated activities to impact muscle function and overall movement control and have positive effects beyond the specific limbs being trained. Therefore, an effort is made to ascertain the impact of interlimb coordinated activities on postural stability and balance, which is crucial in the execution of the majority of functional abilities. Aim of the study is to find out the effect of interlimb coordinated activities on development of postural control in children with spastic diplegic cerebral palsy, with two objectives that were to determine the effect on postural stability when intervention for upper limb is added to the lower limbs in balance training, and to determine the effect of interlimb coordination based activities on postural control and thus balance in children with spastic diplegic cerebral palsy. Alternate hypothesis was interlimb coordinated activities involving all four limbs is effective on development of postural control in children with spastic diplegic cerebral palsy. Null hypothesis was interlimb coordinated activities involving all four limbs is not effective on development of postural control in children with spastic diplegic cerebral palsy. Methodology: it was a pre-test and post-test study design with a convenient sampling technique with 24 participants. Variables used in the study were dependent, postural control, and independent was interlimb coordinated activities including four limbs. Selection criteria: inclusion criteria included children aged between 5 to 12 years of both genders diagnosed as spastic diplegic cerebral palsy with cognitive competence to follow and understand instructions and having balance issues, with modified Ashworth scale grading in between 1 and 2, gross motor functional classification system level 2 and 3, and manual ability classification system level 1 and 2. Exclusion criteria were uncontrolled seizures or epilepsy, dyskinetic cerebral palsy, visual or auditory deficits, any other orthopedic condition or fixed deformities, or received botulinum for the lower extremity during the past 6 months, or who wish to receive it within the period of the study. There were 3 screening tools used in the study, which were modified Ashworth scale, gross motor functional classification system, and manual ability classification system. There were 2 outcome measures used, which were pediatric balance scale and timed up and go test. Procedure: 30 subjects were assessed for eligibility and 6 were excluded. After that, parents and caregiver of subject were explained about the study and informed consent was taken. 24 subjects were divided into 2 groups according with 2 convenient sampling. 12 subjects in experimental group received activities based on interlimb coordination, both symmetrical and asymmetrical, of all 4 limbs combined together, whereas 12 subjects in control group received traditional NDT program for postural control and balance involving 2 limbs only. There were 0 subjects who were lost to post-test. All the subjects were given intervention for 4 weeks, 5 days in a week, 30-minute session in the department, along with home program with the same activities. Activities chosen for experimental group were swinging on T-swing, kneel walk holding ball or bars, squat to stand holding a ball, quadruped in a vestibular board, crawling, cycling, sitting on a physio ball, picking up objects with both hands from right to left and vice versa, and walk while pushing a ball. Data analysis was done using IBM SPSS statistic 29.0. Mean and standard deviation of participant ages were calculated. Within group analysis was done using Wilcoxon sign rank test for pediatric balance total score, while for tug test, similarly pair T test was used. For between group analysis, Mann-Whitney U test compared independent samples for both outcome measures. Statistical significance was set at p less than or equal to 0.05. Results: with n is equal to 24, the mean age of the participant was found to be 8.53 years with a standard deviation of 2.12. This is the descriptive, demographic and screening data of both the groups, including age, gender, 3 of the screening tools which were MMAS, GMFCS, MSES with their numbers and their percentage for both the groups. In Wilcoxon sign rank test, the corresponding p-value for both the groups was found to be less than 0.05 and the negative value of Z suggests that significant difference between the paired group in PBS score before and after intervention, as that the null hypothesis is rejected. The pair T statistics with a corresponding p-value was of less than 0.05 for both groups for tug test indicates a significant difference between time in seconds within the both groups. Therefore, intra-group analysis demonstrate significant impact of interlimb coordinated activities on postural control within the same group. These are the 2 graphs depicting the same thing of 2 outcome measures. Using Mann-Whitney test for intergroup analysis, the test revealed a significant difference between the 2 groups. As can be seen here, the p-value is less than 0.05 for both groups. Negative Z value suggested that null hypothesis is rejected, and more median difference in score in experimental groups suggests that interlimb coordinated activities had a better significant impact on postural control. This is the difference between mean rank in both groups, suggesting better effect in experimental group. Findings for the experimental group align with the fundamental premise that synchronous movement involving all 4 limbs contribute to enhanced neuromotor recruitment and goal-directed movement. Ferris in 2006 concluded that enhanced upper extremity function can influence coordination between lower and upper extremities. Huang et al. In 2009 revealed in the study that active upper limb effort resulted in increased muscle activation of the passive lower limbs. The observed increase can be due to the potential factor of the spinal connection between upper limb and lower limb neural networks. Arya et al. In 2004 explored the involvement of central pattern generators, which are neural networks that play a key role in generating rhythmic motor patterns, particularly in coordinating limb movements such as walking. Conclusion: this study substantiates the positive impact of interlimb coordinated activities on postural control in children with spastic diplegic cerebral palsy when intervention for upper extremity is added to lower extremity in balance training. Both static and dynamic postural control improved during the period of study. These findings underscore the importance of development of targeted intervention. Limitations were relatively smaller sample size with short intervention period and no future follow-up, and limited levels of GMFCS and MSES were used. Further recommendation: future study should aim for larger and more diverse participant groups with a long duration randomized trial, and correlation between static and dynamic balance can also be observed. These are my references. Thank you.
The third presenter is Dr. Madhu Mitra from Chennai, and her topic for today is a systematic review on the application of cognitive orientation to daily occupational performance approach for children with developmental coordination disorder.
Check.
Your time begins now.
Good afternoon, everyone. The topic of this research paper is a systematic review on the application of cognitive orientation to daily occupational performance, that is the COOP approach for children with developmental coordination disorder, DCD. DCD is a movement disorder in which the children experience difficulties in the acquisition and execution of coordinated and controlled movements, leading to marked impairment in ADL and academic achievements. DCD is manifested as clumsiness, slowness, and inaccuracy in the performance of motor skills. Prevalence of DCD among 5 to 11-year kids are about 5 to 6%, and males are more commonly affected than females. COOP is a top-to-down approach which was introduced in the literature by Paediatrics et al. In 2001 as an intervention to improve real-world performance in children with DCD. COOP is an individualized, client-centered, and activity-oriented intervention that enables skill acquisition and solves motor performance issues using cognitive strategies. Need for the study? Though this approach has been utilized for various conditions in OT practice and has been published in various journals worldwide since 2001, there is still a need for producing a collective analysis and to emphasize on the effect of COOP approach for children with DCD. The purpose of this systematic review is to deliver a meticulous summary of the available evidences on the application of COOP approach for DCD children. Objectives: 1 is to analyze the effect of applying COOP approach for DCD children. 2 is to summarize the utilization of various methods in applying COOP approach for DCD children. 3 is to identify the occupational areas that are addressed by COOP approach for children with DCD. Methodology: according to PRISMA guidelines, this systematic review was conducted in 4 stages. In stage 1, that is the identification stage, search terms were developed and 789 articles were identified. These are the search terms used. In stage 2, that is the screening stage, 366 articles were obtained after the removal of duplicates. These articles were screened for title and abstract, and 46 articles were obtained. In stage 3, that is the eligibility stage, articles were included in the study if they were published in peer-reviewed scientific journals and are available in English language, if they were published between the years 2001 and 2021, if they used COOP approach for DCD children, if they compared COOP approach with other intervention procedures, if their population included DCD children with or without any other associated conditions. Articles were excluded if they don't have full text, if they addressed other intervention procedures along with COOP approach for a single group of children with DCD. In stage 4, the obtained 14 articles were assessed for risk of data bias using the modified Townsend-Black checklist tool. This PRISMA flowchart summarizes the systematic review. After this, an evidence table was created by adding all the basic information needed, and the studies were reviewed. Results of search: from the obtained 14 articles, 5 studies belong to level 2B evidence, 4 studies belong to level 3B evidence, and 5 studies belong to level 4 evidence. Summary of quality of evidence: 7 studies indicated blue in color are of good quality of evidence, 4 studies indicated green in color are of fair quality of evidence, 3 studies indicated red in color were of poor quality of evidence. General characteristics of included studies: only 1 study had equal intake of both boys and girls, 6 remaining studies didn't include girls in their studies. Intervention characteristics: 9 studies had 60 minutes as the duration of the intervention, 6 studies conducted 1 session per week, only 8 studies had follow-up evaluation. Method of application: 10 studies had conducted intervention on one-to-one basis, 4 studies had applied the COOP approach in group format. Occupational areas addressed: only 12 studies have reported the goals chosen by the kids and their parents, 9 studies had ADL related activities, 10 studies had education and play, and 5 studies had leisure related activities. Discussion: effectiveness of COOP approach. The initial objective was to determine the effectiveness of using COOP approach. To strengthen the evidence, 2 studies answers the Two studies give the neuroscientific justification for answering the question. Intervention character. Showcase the efficient use of COOP approach for DCD children to enhance various outcomes in areas such as aerial play, leisure, and education. Limitations. Factors such as insufficient search terminology may have yielded only part of the eligible studies. Current review study used evidences of level 1 to level 4, suggesting for the consideration of levels of evidence while interpreting the results. Future recommendations. More of level 1 studies are needed to be performed. Future research is required to determine the longer lasting benefits of this COOP protocol on children with GCD. Researchers can concentrate more on applying the COOP intervention for younger children and also with population including girls as their subjects. Involvement of parents and teachers are needed to maximize generalization and transfer into daily life. More studies are needed to research the most effective way that parents and teachers can be engaged in providing with instructions. These are my references. Thank you.
I now call upon Dr. Kausalya M. from Kerala, and the topic that is going to be talked is on effectiveness of individualized multi-component intervention for sensory food aversion feeding disorder in children, case series.
Good evening, everyone. My topic is effectiveness of individualized multi-component intervention for sensory food aversion feeding disorder in children. It's a case series. And the feeding problems consists of various disorders that disrupt the age-appropriate eating habits. And it typically occurs between the age of 1 to 3 years, and it causes inadequate growth, insufficient intake, and failure to progress through developmental feeding stages. And there are many problematic eating behaviors. There are eating small meals, not interested in food, eating slowly, refusing to try new foods, and avoiding certain foods. And there is a lack of research in the classification of feeding disorder, and the prevalence of feeding problems is about 25 to 45 percentage in the typically developing children. Occupational therapists are aware with the sensory defensiveness, especially about the tactile defensiveness. So when there is a problem in the sensory issues, the sensory integration therapy would be the treatment choice. The other choice is behavioral treatment. And the evidence of this protocol is still developing. Therefore, this study plans to evaluate the effectiveness of multi-component intervention for sensory food aversion feeding disorder among children. The research question is, will children with a sensory food aversion feeding disorder benefit from the multi-component intervention? The aim of my study is to find out the effectiveness of the multi-component intervention for children with sensory food aversion feeding disorder. The objective of my study is to increase the acceptance and consumption of non-preferred food, as well as to improve the parental positive coping attitude towards the child's mealtime behavior. So the author, Mitchell Suresh, conducted a study on multi-component treatment for food selectivity in children. So in that study, they concluded 4 children with food selectivity demonstrated increased food acceptance after the intervention. And my studies is a case series, and the population included where the children reported with feeding issues in the preschool, and the sample size includes 7 children were included. I used convenient sampling, and the inclusion criteria were 3 to 6 years of age with both genders were included. And the children who met the criteria of sensory food aversion disorder according to the Chattu's classification. The Chattu's classification includes child who refuses to eat specific foods with specific taste, textures and all. And onset of food refusal occurs during the introduction of different types of food. Child eats better when offered preferred food, and child should have the specific nutritional deficiencies or oromotor delay or both. And the exclusion criteria are children with neurological, musculoskeletal and cardiovascular disorders, and who are receiving the feeding therapy, and children with anatomical or oromotor structural issues were excluded. And in my study, I used screening tool as a Chattu's classification, and the outcome measures are behavioral pediatric feeding assessment scale, child sensory profile, food preference questionnaire per children. And on the procedure, initially I got approval from the scientific committee and ethical committee. Written consent was obtained from the head of the institution, and need and purpose were explained to the parents. So based on the 4-day observation of the children during their meal time and discussion with their parents, the children were screened for the sensory food aversion feeding disorders. And multi-component intervention was given for 30 days. Post-test was done, and descriptive analysis was done using the CARE guidelines. So according to the CARE guidelines, presentation of symptoms, the majority of the child have the symptoms of sensory food aversion, sensitivity to certain foods, selective eating behavior, and exposure to these foods leads to the symptoms of gagging, spitting, fear, and vomiting. And through the assessment, I found out that there is a delay in complementary feeding for all the 7 children. And the duration of intervention is for 1 hour for 5 days per week for the 30 sessions. And the 1 hour session is divided into 3 parts. Initially, 15 minutes sensory-based activities were given, and the 30 minutes is for meal time, and the last 50 minutes were parental education were done. During the meal time, I used behavioral techniques, and in addition, parental education were done. These are the sensory-based activities I was given during the intervention, and these are the mealtime pictures. And through the intervention, the outcome shows that there was a significant improvement in the mealtime behavior, and all the children started to eat non-preferred food varieties after this intervention, and the sensory issues were relatively reduced when compared with the first and fourth week of the intervention. And the child started to grade their food size and quantity with reinforcement. And these are the data analysis that supports the outcome. And this table that shows the post-intervention, post-test score is increased when compared to the pre-test scores. And this graph that shows there is a improvement in the post-test scores when compared to pre-test. And this table shows that there was a significant difference noted in the both components of behavioral pediatric feeding assessment scale and the oral component of the child sensory profile. And there was a significant difference noted in the food preference questionnaire also. And with that, I conclude the multi-component intervention is effective for improving non-preferred food acceptance and consumption. And it also equips mother to improve mealtime behavior in typically developing children. And results from the current study would be beneficial for the sensory food aversion feeding disorder. The limitations include it is a small size sample, and there is no control group, and it didn't find out the effectiveness of the intercomponent of the intervention. And for future recommendation, there is a lack of study in the sensory food aversion disorder. So there is a need for the well-designed population study on that condition. And it would be better to have a dietitian evaluation before and after the treatment, and research could be conducted on a large sample size. These are my references. Thank you.
I call upon Dr. Simran Redkar from Chennai. And her topic is enhancing visual perception and visual motor integration in children 4 to 12 years. And it's a systematic review of technology-based intervention.
Good evening, one and all. The topic is enhancing visual perception and visual motor integration in children ages 4 to 12 years, a systematic review of technology-based interventions. To begin with, visual perception allows an individual to process visual stimuli to identify what we see and thus understand the world in which we live in. It is a primary factor in cognitive development, learning, and many other daily activities. Evaluating and intervening these deficits is a critical area for professionals, especially occupational therapists working with children and adolescents. Interventions targeting visual perception and visual motor integration are broadly categorized as traditional and computerized intervention within the clinical settings. Traditional visual perception training programs encompass copying figures, matching shapes, block constructions, puzzles, and paper pencil exercises. While these programs can be beneficial for children with visual perception dysfunction, they are often characterized by repetition and may lack elements to keep individuals motivated. This becomes particularly challenging for children with disabilities who may struggle with repetitive practice of functional activities due to inherent factors such as shorter attention span and cognitive impairments. The current literature lacks a comprehensive synthesis and critical analysis of interventions designed to enhance visual perception and VMI in these children. Despite the growing recognition of the pivotal role of these skills that play in academics, cognitive development, and overall well-being, there still exists a gap to understand the effectiveness of these intervention strategies. The trend shift towards technology-based intervention is on a rise, and the utilization of such interventions offers advantage of delivering various sensory stimuli and prompt feedback. This approach also boosts the intrinsic motivation and facilitates learning. Research has also shown that visual perception and VMI in children through computerized training is more effective than traditional paper pencil methods. These interventions have an additive advantage of making the intervention fun and enjoyable, thus adding to its efficacy. Therefore, the systematic review aims to evaluate existing interventions that are technology-based to provide a nuanced understanding of evidence-based practices for optimizing visual perception and VMI in children ages 4 to 12 years. The research question we developed was, what are the effectiveness of implementing technology-based intervention on visual perception and VMI in children ages 4 to 12 years? For which we selected the design of systematic review and followed the guidelines of PRISMA. We first registered the review on Prospero, and we conducted a comprehensive literature search using the electronic database from Scopus, PubMed, ProQuest, and OTSeeker, and some printed journals. Studies that targeted on technology-based intervention, either on visual perception and or VMI, for children ages 4 to 12 years, published between the years May 2013 to April 2023, available in full text in English, with level 1B, 2B, and 3B were included in this review. Studies that were level 1A, 2A, 3A, level 4, and level 5 were excluded. The following MASH terms were developed as search strategies for visual perception and technology-based interventions. From the comprehensive literature search, records to the electronic database were reviewed to be 559 and from printed journals 16. These were reviewed by first 2 reviewers, after which if any article was unsure of whether to be included or no, was then reviewed by 2 independent reviewers. After duplicate removal, the number of studies we had was 424. These all were subjected to title screening, after which some were excluded and 411 were then excluded from abstract screening. The full text eligibility was undertaken by 13 studies, and finally the qualitative analysis was also conducted on these 13 studies. The results from the scope of our systematic review, 13 studies were within the alignment of our scope, of which 11 were computer-based and 2 were iPad-based. The highlighted ones are the computer-based interventions that are used, such as contrast, augmented feedback, virtual reality, therapist-guided game-based intervention, multimedia visual perception training, kinesthetic game-based interventions, Wii games, and MOVE-R immersive rehabilitation therapy. Only 2 studies employed iPad-based interventions. All these 13 studies have got a significant rise in the visual perception or the visual motor integration skills. The reviewed studies encompassed a diverse range of population, with 3 studies focusing on developmental delays, 2 on dyslexia, 3 on cerebral palsy, 2 on hearing impairment, and 1 each on Down syndrome, hydrocephalus, and intellectual disabilities. Among the 13 studies, 5 studies exclusively worked on visual perception skills, 3 on visual motor integration skills, 1 on visual motor coordination, and the remaining studies worked on visual perception, along with an additional element like cognitive functions or upper extremity skills. The most commonly used assessment to assess visual perception in this was the test of visual perception skills, and to assess VMI was Berry VMI version 5 and 6. Occupational therapist employed majority of the assessment, and 1 each was employed by a physiotherapist, special educator, and a multi-D team. The risk of bias assessment was conducted through a revised tool for assessing risk of bias from the Cochrane database of systematic reviews. We divided the risk of bias into 2 sections, one that considered RCTs and non-RCTs, which had a control group. 9 studies fitted this criteria, amongst which 3 had a high risk of bias, 2 had a medium risk of bias, and the remaining 4 had a low risk of bias. The second set of criteria was pre-post test studies without an control group. 4 studies were in this type of studies, and all 4 had a low risk of bias. Our discussion suggests that the inclusion of the studies within the specific age range underscores the critical developmental period when visual perception and VMI skills are fundamental for various cognitive as well as motor functions. Several key factors emerged during this review, highlighting the diversity of technology-based intervention and its impact on these skills. The utilization of imaging measures, specifically functional magnetic resonance imaging, was only used in 1 study. We have highlighted this because this study indicated more activation of the superior and inferior parietal lobes that dealt with spatial manipulation, as well as precentral gyrus and dorsal premotor cortex. There was a varying degree of durations, except for 1 study, which was conducted over a year. This tells us about the long-term benefits of these interventions. There were no studies in the realm of Indian research, and there were additional benefits of technology-based interventions as well. Therefore, there's a pressing need for future research to incorporate more imaging to get deeper insight on and reflecting on our interventions. Our study, however, only selected studies that were published in English and used 4 databases. This study implies occupational therapists with insights to use technology in a more safer way and collaborate with other professionals of neurology and technology to contribute to a holistic understanding of intervention plans. In conclusion, the systematic review reveals the efficacy of technology-based intervention as a valuable intervention in promoting these skills in the ages of 4 to 12 years. It also highlights additional benefits from technology and the trend towards virtual world being more constructive and a beneficial platform. However, future studies are needed to qualitatively and quantitatively analyze these interventions in the Indian context to promote evidence-based practice. These are my references. Thank you.
I now call upon Dr. Meenakshi Batra from New Delhi. She will be talking on landscaping the therapeutic powers of play in children with neurodevelopmental disabilities. And this paper is under non-competitive presentation category.
Good evening, respectable chairpersons, my senior members, faculty members, and all the delegates. Myself, Dr. Meenakshi Batra, and the topic of my presentation, landscaping the therapeutic powers of play in children with neurodevelopmental disabilities. This song you can play from here. Doesn't open from here. Hmm.
Technical problem.
All right, the topic of my presentation is landscaping the therapeutic power of play in children with neurodevelopmental disabilities. Play is a form of self-expression which fosters learning and skill development across multiple contexts. In neurotypicals, the children with neurodevelopmental disabilities have limited play participation due to underlying physical, neurological, or sensory processing problems. They either lack the primary occupation, that is play, or they play in an atypical or stereotypical manner, which renders them to limit their interpersonal socialization skills, further limiting the socio-emotional development and resulting in the limitation in their adaptive behavior. As a specific structure of play-based therapy is neither defined nor used as a standard of practice for treatment in OT, so the study was taken up realizing the potential benefits of landscaping the elements of socio-emotional concern into the therapeutic framework for play engagement. And the primary aim was to see the efficacy of socio-emotional strategies within the sensory motor framework for augmenting the play engagement in children with neurodevelopmental disabilities. It was a quasi-experimental control design and 3 test instruments was used: test of playfulness, repetitive behavior scale, and socio-emotional developmental checklist was used. These are the assessment instrument. TOP, which is test of playfulness, based on 21-item questionnaire was used, and scoring from 0 to 3 was given based on extent, intensity, and skillfulness. The repetitive behavior scale is a 43-item scale, and the scoring was done from 0 to 3. And the socio-emotional component having 5 domains, each tested from score 0 to 4, having 19 items in total, including the 5 major domains, which are self-awareness, self-management, social awareness, responsible decision-making, relationship skills across different ages. The baseline evaluation was done for the 30 children for all these assessment instruments, and the age range considered was 5 to 10 years. Those having the diagnosed or established cases of neurodevelopmental disabilities were recruited from the institution. The institutional ethical committee approval was taken and informed consent obtained. The subjects were allocated to either of the 2 treatment groups. Group 1, which was based on the sensory motor framework in addition to the socio-emotional strategies, while in Group B, only the sensory motor strategies or conventional strategies were used. It was a home-based intervention protocol, which was given in both the groups, followed by re-evaluation after 2 months. But after the 15 days, follow-up and review of the treatment module was being done within the department. So the major strategies in treatment for Group A, where the socio-emotional strategies were incorporated within the sensory motor framework, included 4 major elements: effective attunement between the child and the caregiver, zone of proximal development to initiate and respond to joint attention, use of representational gestures and embodied simulation via these activities, which is given in the next slide. Pre-play, which is the child's innate repertoire of play domain, sensory motor activities based on different sensory processing items, based on the interest and individualized selection. Floor time play, body scheme activities, rhythm generating activities, using the representational gestures in various combination of bodily interaction was being given, and this was included within the zone of proximal development. That is what was the innate desire of the child to choose the activity that was modified, and the circle of communication by using common joint referent of attention was being taken. Other than that, the 3 major elements of the socio-emotional concern was embodied simulation using different socio-emotional strategies like social approval, social referent, emotional appraisal during and after the task, play, and the games was being used and told to the parents. Visually guided attention play task for social engagement, and social narratives or the perspective taking, which was one of the element which was included in the last in the hierarchy within the social context. These are some of the slides, so just to make it clear that what were the activities that was being trained in the as a module in the department and carry over using any of the item of child's homely context was being used using different play items. body scheme-based gross motor task in various combination, and that too was based on the joint attention and social referent. Synchronization of bodily actions. One of the elements which was extremely important in socio-emotional strategy-based sensory motor program was free play that was encouraged, and there was no obstruction that was being told to the parent to block that. In fact, the circle of communication was built on the free play. Then the emotional contagion and the lexicon was built. That means the parent and the child had to foster the emotional lexicon is the understanding of the emotions and its relation with the respect to the live facial figures, gestures, and the postures. On self and on others was being done, and the module was being practiced in the department. Representational gestures using different referent item, object, or person, along with social referencing throughout the task was also advocated. Then visually guided joint attention task in both the modes, that is continuous mode and shifting attention mode with social regard and referencing. Anywhere the child was not allowed to perform the activity in isolation. Then the activities which the child was of innate desire to perform or interest-based, social approval and referencing embedded within the playful task in the social context in a group of 3 or 4 people was also being carried over. And some of the activities which required the description or the social narration within his context of cognitive understanding was also added to initiate and respond to joint attention. The treatment protocol based on the conventional strategy or sensory motor framework included all the activities which we use in the department and the carryover of some similar kind of the activities at the home. Tabletop-based cognitive educational activities with instruction-based activities, toys, educational toys, the instruction-based play activities, catch and throw, which we use, target-based games, fine motor activities that we use. So these were some of the activities that was advocated using different method at the home also. Then as the distribution found was skewed, the between group analysis was done using Menn-Whitney test, and within group analysis was done using Wilcoxon sign rank test with level of significance as 95% and power 90 using SPSS 20. So when the comparison was done on all these 3 parameters chosen, there was a difference. There was no significance between the group on repetitive behavior scale, RBS, whereas on socio-emotional and test of playfulness, there was a significant difference on skillfulness. While both the groups showed the improvement in within group, but the level of significance was found higher in the group where socio-emotional strategies based on the sensory motor framework strategies was used. So as the improvement was noticed in both the groups in certain items in terms of the RBS also, as we had used both the groups sensory motor based activities and engagement activities of vivid nature. Therefore, it was attributed to the fact, while it was observed that children in group A showed better socio-emotional responsibility with their caregivers, the strategies for playful interaction within child circle of communication along with social approval and social regard simultaneously during sensory motor activities and while interpersonal communication attributed to fostering the play engagement of the child. Further, the embodied simulation of emotional expression, socio-emotional expression across multiple contexts help in generation of emotional contagion, that is the reciprocation of the same emotions, which is an indicator of socio-emotional skill. So it can be concluded based on the study, although it needs a lot of generalization because of the limited sample. Socio-emotional strategies-based framework fosters the active play engagement behavior in children with NDD, neurodevelopmental disabilities, and therefore the landscape of environmental variable in multiple contexts requiring the parental active engagement based on the individualized play repertoire of the child to foster the socio-emotional skills and addition of socio-emotional strategies helps the children with neurodevelopmental disabilities widen the horizons of therapeutic concerns. And the list of references. Thank you.
May we request, okay, we request the presenters to come on the stage, please. Come on, Latans. Well, now the session is open for questions. We will try to limit our questions, please, which will be a boon for our presenters. As we've got strict instructions, we are definitely running very, very late. Anybody for Dr. Sanjeev Kumar? Sanjeev Kumar? Anybody from the audience? Yes? Mike?
Yeah, yes, Dr. Sanjeev. Yeah, it was a nice presentation. I just want to know that what was the post effect? Immediately you saw the swallowing and all the effect, but did you review it? Did you follow up after some days or some weeks whether the treatment was effective or that was just a temporary?
No, actually, I didn't do the proper follow because during that time was COVID was there. So due to the reason, I couldn't do proper follow. But the effectiveness was there. I observed the patients.
No, but during COVID, you were physically giving the drooling, the pressure, no, the roller you were applying. You were doing or somebody else was doing?
No, I was done on the
Ah,
after during second wave time.
yeah, just wanted to review whether this.
Yeah, it was effective.
It was effective. Thank you.
You can suggest or maybe give in, but I don't think you can ask a question. You can. All right. Yeah, because you are in the non-competitive.
Yours was a vibration, right? Over the different facial regions. Because I am practicing all these techniques, so I just had one suggestion that because we do not use all these kind of a strong
Yes.
electric input, specifically the vibratory, that is considered as a very strong input.
Yeah.
So we do not use over the regions where there are maximal innervation, and face is one of that.
But did the child help? Was the child comfortable while when you are giving?
Here only I have one suggestion. If in case we want to use that, under 5, it is not recommended as such because of the poor myelination up to age of 5. But you can use a limit up to certain facial regions because you incorporated a lot of facial regions. That is the only concern.
But some literature has suggested we can use vibration below like 100.
100 cycles per second used. Thank
Well,
you.
I think, Meena, your suggestion could be taken. You can do a long study again. There's nothing wrong. We always have to keep learning, and maybe somebody else will review your papers and you can help them out also. Thank you.
Thank you.
Any question for Dr. Kanishka Mehta? Can you please identify yourself? We can't see you. Sorry.
Hi, I'm Nivedita Nair from Thrissur. And my question is to you. I think you worked for, you talked about cerebral palsy, spastic diplegia. I had two, one of the first thing is I'm not comfortable with the terminology of spastic diplegia because you mentioned that they had just the lower limbs that were affected. So with my NDT background, what I have seen is that diplegia never necessarily is just the lower limbs. It is that the upper limbs are less affected than the lower limbs. So naturally, when we are training children with interlimb connectedness or, whatever you have presented, obviously when you, include the upper limb training, there is going to be a good change. My second point is in the control group, you said they went for NDT. being an NDT therapist, I do not think that we would give just two-limb activity. There isn't a two-limb activity. It's a whole body activity. We work on rotations, we work on dissociations. So putting the control group in an NDT, I wanted to know whether it was just that or it was some passive form of therapy. Thank you.
Yes, ma'am. Actually, various systematic reviews that I have seen in the studies for balance training for improving postural control, they have mentioned the NDT therapy, but no upper extremity intervention were there in any of the studies. Like they were even using elephant assisted therapy, they were using virtual reality, but no upper extremity intervention was found in any systematic reviews. That is why I added upper extremity intervention for balance training specifically.
You want to ask? All right.
Thank you very much for your presentation. My name is Gokulam and I'm an occupational therapist. I just had a question for her, whether or not she took into account the 2019's systematic review, the traffic light evidence-based system for cerebral palsy.
No, it's all right.
It was a 2019 published paper where evidence-based interventions for cerebral palsy was included, and it also ma'am mentioned that she is an NDT-based therapist, but that study says that NDT does not have strong outcomes for motor-based outcomes for cerebral palsy. So I just hope that you do that, because since you are working on research with CP, that would be a great adjunct to that. Thank you.
Thank you so much.
All right. Thank you so much. Yes.
Hi, I am Meenal from Gurgaon. I really want to ask what activities actually given to your control group. As ma'am said that NDT is not specifically for lower limb only and that kind of activity. So what you have given?
A control group included activities like standing on a line, specifically tandem standing, walking on a straight line, backward walking, sideways walking, eyes closed standing, eyes open standing. Just those simple balance training exercises that we do in our department.
Are you? I think we could.
Yeah,
Thank you. All right. Thank you. Any question for Dr. Madhu Mitra? No question.
Yeah, hi. You have done the review, yeah.
Yes, ma'am.
So I just want to know what made you think of reviewing this cognitive orientation to daily occupational performance? On what basis you thought only cognitive? Why not other things also to be involved?
Actually,
Because it's you can't only have one aspect of the therapy. We have to see on the whole. So other things also can affect, no?
yes. But actually, the main motive of this review is the application of this approach for PCD children. So cognitive orientation to daily occupational performance is the approach which was like published in the year 2001. So I have took that approach and the effectiveness of that approach on DCD children.
Okay, no other approaches were used
No, ma'am,
along
only
with-
two.
Okay,
Yeah,
thank you.
sure. Thank you.
Can we go to the other speaker now? And that, any questions for Dr. Kaushalya? I don't see any hands. Or you do? Saumil? Yes.
I'm Dr. Ganapati Shankar from Chennai. My question is, during your presentation, you mentioned the qualitative research. But in the result, your data you quantify the result. What is the difference between qualitative and quantitative research?
So in this study, I used CARE guidelines to describe the cases. So for the standard method, I want to clarify whether it is effective or not. To check that, I used quantitative scale.
The study design is correct?
Yes,
Methodology?
yes.
Qualitative research?
Qualitative research.
Okay, thank you.
Saumil, you wanted to ask?
Good evening, everyone. Myself, Dr. Saumil from Mumbai. If I'm not wrong, you had presented the mealtime presentation. I just got confused between the speakers. So I had a question for you. Did you consider inner drive of children anywhere in your study or intervention? The basic will or inner drive?
Sorry, sir, I couldn't understand. Can you repeat the question?
Did you consider inner drive of your children anywhere relevant in your study or intervention?
I told that there are 7 children were included in the intervention, and I used 3 scales to assess their behavioral issues and sensory issues. The behavioral issues were assessed by pediatric scale, and the sensory issues were assessed by the child sensory profile scale. And their food preference were assessed by the food preference questionnaire.
That's what. Was inner drive considered anywhere while considering the study, or that's the only question? No problem.
Thank you, Saumil. Can we move over, please? For Dr. Simran. Anybody for Dr. Simran? Any question to her? No?
Yeah, Dr. Simran. Actually, I shouldn't say this is one of this for your PhD research programs. Yeah. Yeah. So you have done a review. So first you did the review, and then on that basis you wanted to continue with your what you said is technology-based intervention.
Yes.
So which type of technology-based intervention you were looking out, which you have used it in your PhD studies?
Actually, I was not looking at anything specific as per se. I was just looking at the diversity of what kind of technologies have been incorporated in children with different conditions. So to get an overall idea as to what aspects were considered, what type of intervention was given, how long, how frequent was it given, was the idea behind the systematic.
So did it help you?
Yes, ma'am.
Okay,
Definitely.
thank you.
Can I comment on it, Dr. Simran? Excuse me. Of course, your study is something looking out for, but you did mention screen addiction.
Huh?
Screen addiction. Screen addiction, we mean they get addicted. These are all technology based, right?
Yes.
Right. So did you come across anybody where children get addicted to your smartphones, the computers, whatever you are using to achieve visual perception and visual motor? Would you consider that as an occupational therapist? Because, and would you even bother or wait? And how long will your treatment program would remain? And would you be later on wean out? Because it's very, very difficult you get so many, the youth who are addicted to it and referred to psychiatrists and referred to occupational therapists. So would you consider that?
Thank you for the question, ma'am. Actually, definitely, yes, I would consider it as one of the important factor, which is why the age that we have selected is 4 to 12 years, keeping in mind that that's an age when the development is partly complete, and that's an age when the children are actively more exposed to the virtual world. So the idea behind reviewing this was also to get an overall judgment of how often the therapy protocols are used, so as to set a minimum bar and a maximum bar, and to advocate parents or other therapists or any other professionals working on technology-based interventions to give them a generalized guideline of safely incorporating technology-based intervention.
So you would be considering it,
Yes,
or
ma'am.
you? will?
Definitely.
Thank you.
Thank you.
Of course, those marks will not be counted for Meenakshi, but in case anybody wants to comment or say anything, please don't leave her out. Anybody? Not you, Dr. Batra. Saumil.
Thank you for the wonderful study, ma'am.
Yes.
Just one small question. You mentioned a lot about play-based interventions, and during the list of interventions, you also mentioned a lot about activities. So I just wanted to understand, how did you get a mix and match of play as well as activities in the intervention?
Okay, thank you for the question. It was not exclusively play-based activities. Group A, I made two groups. Both I incorporated play, games, and other sports activities. And with Group A, I incorporated the socio-emotional aspects and strategies so as to incorporate that within his socio-emotional skill development. Whereas in Group B, I used the play activities, which is based on purely sensory motor framework. That was it. Feedback based. Thank you.
Thank you all.
Thank you.
And congratulations, and hope to see you at every conference, with more papers. And take it very lightly, but sincerely, that definitely we can improve and go much better and do much more for our profession. Thank you very much.
Thank you, ma'am.
With this, we would like, on behalf of my co-chairperson, I would like to thank the organizing committee as well as the scientific chairman and the team for giving us this opportunity to chair this session number 5. Thank you so much.
We'd like to invite the chair people to kindly give away the participants their certificates. Dr. Sanjeev Kumar. Dr. Kanishka Mehta. Dr. Madhu Mitra. Dr. Kausalya. Dr. Simran Sandeep Redkar. And Dr. Meenakshi Batra. I'm one. Ma'am, 1 minute. They're clicking a picture. Now we'd like to, Bole ma'am is already on stage. We'd like to please ask Bole ma'am to kindly felicitate Sir. And Dr. Bijlani ma'am to kindly felicitate Zareen ma'am.